Good morning, everyone. Welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is Part 1 CMS CY 2025 Proposed Rules. PYA is happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the questions pane of the control panel. Also, immediately following the end of the webinar, you will be asked to complete a short survey and submit any additional questions. We will respond to questions posed after the webinar via email. We have posted in the handouts pane of the control panel a PDF copy of the slides for your reference. Also, you will receive an email later today with a copy of the slides and a recording of the webinar. With that, I would like to introduce our presenters, Martie Ross and Kathy Reep.
Morning, everyone. Thank you for joining us today. And boy, do we have an aggressive agenda for the next hour. This was billed as a CY25 proposed rule webinar, but there's been other parts of our government busy beyond our friends at CMS. So we're also going to address some proposed and final rules that have come out of ONC, as well as some impacts of recent Supreme Court decisions, because certainly the last week in June, first week in July, were an exciting time as we waited patiently each morning to see what the Supreme Court came up with next. So let's get started with the big rule, of course, which is the 2025 hospital outpatient PPS proposed rule. So Kathy, tell us what they're going to pay us.
Sure. For those who are not ready for this, Martie is driving the slides for me, and therefore we're going to see how this goes. So the proposed
quick,
rule,
Kathy, it's going to go quick.
Okay. All right. The main thing I have to emphasize on this slide is that the comments are due September 9th. So please make sure that you get your comments in, because there are some provisions that we're going to talk about. Martie and I are sharing this discussion, but some issues that you really are going to need to vehemently comment about. So let's move on. We've got a top 10 list again related to what all we're going to address, but just let's move right into the payment rate updates, the most important information, I guess, from a finance perspective. They are looking at a sad 2.6% increase in your payment rate over 2024. I think all of the coverage that I've seen so far is folks decrying this small update. Should be significantly higher due to increased costs, salary costs, etc. The reason for this 2.6% update is a market basket of 3%. You're going to see that come up later, less statutorily required productivity adjustment. I think it's the market basket that people are concerned about, not that productivity adjustment. We knew that would be there, but the measurement of market basket is not appropriate. It's going to take our conversion factor from $87 up to $89, essentially a $2 increase. And for those hospitals that do not satisfy the outpatient quality reporting requirements, their payment would be about $87 moving forward. To calculate the rates, they did use 2023 claims data and 2022 cost report data. This will be updated or could be updated by the time we get a final rule in early November. For ambulatory surgical centers, you know that basically you are paid a percentage of the OPPS rate, and therefore you too are going to get that 2.6% increase as currently proposed.
So Kathy, as an advocate of folks commenting, what is the nature of the comments regarding the market basket and CMS's calculation on the market basket?
I think you need to argue what has changed in terms of your overall costs of care. Again, looking at the fact that they are using 2022 cost data, they're using cost reports that were audited from that time period. There have been significant changes in terms of increased salary costs, increased federal requirements on you, operating costs, increased costs of drugs and pharmaceuticals. Address that in your comment rule. The inpatient only list, which we thought was going to go away a couple of years ago, and then it came back immediately. They continue to update the inpatient only list, and I wanted to include this slide in here just so that you recognize that these were all services related to liver allografts, and that they are moving on to the inpatient only list. It makes non-clinical person that I am, it definitely makes sense to me that these would be inpatient only, but recognize that this is an update to the IPO list.
And nothing came off, right?
Nothing came off.
Okay.
Last year we received a new outpatient mental health benefit or payment program under the Medicare outpatient program, the intensive outpatient service IOP, the intensive outpatient program. And this is ties in with partial hospitalization, but it's for those patients who need fewer services than the partial hospitalization. They have separately published the rates for the intensive outpatient and the partial hospitalization based upon where those services are provided, whether it be in a community mental health clinic or in the inpatient and the outpatient hospital program. One thing that you need to recognize, and Marty, I think you clarified earlier when we were discussing this, that payments for rural health clinics and other sites was addressed in the physician rules, so that will be covered in the next webinar. Again, rates vary by site and by the number of services per day. A new provision that was included in the proposed rule, going back to a requirement of the Consolidated Appropriation Act of 2023, relates to separate payment, add-on payment for non-opioid treatments for pain relief. And this would be essentially applying to both drugs that are dispensed both in the hospital and the ambulatory surgical setting. And it is a temporary program running from 2025 through 2027. And the payment rate, the add-on payment amount for these various drugs would be limited to 18% of the OPPS payment rate for the particular service with which it's provided. The table I've attached in the slide deck just gives you a proposed list of the products and the add-on payment that would be applied to each of these drugs.
So there we go. So if you recall, when we discussed the inpatient proposed rule back this spring, we talked about a request for information that CMS included on addressing the maternal health crisis in the United States. And in that proposed rule, in the RFI, CMS went into great detail on really the alarming statistics around maternal death and other complications related to pregnancy, childbirth, and just the whole entirety of perinatal care. And CMS received many comments addressing that RFI, but what we had expected was either we'll see a condition of participation proposal showing up in the inpatient final rule, or we'll just wait as usual for an annual cycle. Well, surprise, I think for the first time ever, we received in the proposed rule new hospital and critical access hospital conditions of participation. And so CMS has made proposals to include a new COP around obstetrical services and also make significant revisions to 3 other conditions of participation, including the quality assurance and performance improvement COP, the discharge planning COP, and then the emergency services COP. COP, just very briefly, these are the conditions of participation primarily related to health and safety that an organization must satisfy and maintain compliance to keep its Medicare participation agreement. And typically either state surveyors or accreditation agencies will review on a regular basis a hospital, a critical access hospital, their compliance with these conditions of participation. Any deficiencies that are noted then are required to be addressed by the hospital, with that, of course, risk of losing their Medicare participation agreement. So obviously the COPs carry a great deal of weight to hospitals and their compliance activities. So let's begin with the new proposed COP on obstetrical services. Now, similar to emergency services, surgical services, these are referred to as, this is referred to as an optional COP, meaning as a hospital or as a critical access hospital, you are not required to provide OB services outside the ED. But if you elect to provide that service, you are then obligated to provide the service in compliance with the conditions of participation. And so CMS notes that currently there are just shy of 5,800 hospitals that provide OB services and 513 critical access hospitals, or 38% of all critical access hospitals are still providing OB, which I kind of found surprising that that number was so high, given the stories we hear about maternity deserts in rural areas. But what the OB COP is intended to do is finally create national standards around the operation of OB units by hospitals. And there are 3 core requirements you'll find in this proposed COP, beginning with organization and staffing, that you must have if you have OB service, it must be supervised by an experienced registered nurse, nurse practitioner, or MDDO, and that you must, as part of your medical staff privileges, delineate specific OB privileges for all practitioners based on demonstrated competencies. So this will become a higher level of expectation with regard to OB privileges. Secondly, the COP addresses delivery of services and requires that you must have adequate provisions and protocols that are consistent with nationally recognized evidence-based guidelines. Now that sounds like generic language, and we tend to sort of read past generic language, but the explanation of this COP in the proposed rule is important, because the expectation CMS has is that each hospital that provides OB services will specifically identify those nationally recognized and evidence-based guidelines they are following, and that they reference in their policies and procedures those guidelines, as well as processes for updating the policies as those guidelines develop. Same with regard to provisions, that you have your OB delivery rooms and postpartum rooms appropriately equipped to address the needs of the patients that you see within your facility. Also, there is a specific requirement that each L&D room or suite must have a call-in system, a cardiac monitor, and a fetal Doppler monitor within the room itself. So this is really the only place in any of these requirements where CMS is so prescriptive in defining what must be in every room or suite providing OB services. Finally, the OB COP addresses staff training, specifically requires that the organization's governing body identify and document which staff within the organization must complete annual training on best practices and protocols, and also what you've identified within your quality assurance and performance improvement program as identified needs for enhanced training among your organization. So yes, follow the guidelines, that's critical, the training must be tracking to that, but also what are the specific issues you've identified in your organization, and how are you going to address that through your appropriate training. Interestingly here, CMS adds a requirement that the hospital must be able to demonstrate to either surveyors or accreditation agents that the staff has knowledge on the training topics. So it's not enough now just to do the online training and call it good and certify that you attended the session. You as a hospital are going to have some vehicle to demonstrate that actually folks heard the information and understand the information and have gained the appropriate knowledge. So whether this is post-training testing, some sort of other acknowledgement by staff, again, flexibility to the organization, but you have to be able to demonstrate the staff, in fact, has the knowledge that was shared in the training. So let's talk about the changes that CMS is proposing to make to the quality assurance and performance improvement COPs. And remember, there's both a COP for critical access hospitals and for hospitals. Interestingly, if you recall, the critical access QAPI COP was significantly changed in 2020. We're still waiting for those interpretive guidelines from CMS to provide further guidance on the QAPI COPs, but regardless of what we're waiting for, CMS now intends to amend, or at least is proposing to amend the QAPI COPs to add these additional requirements around OB services. And specifically, those in leadership positions within the organization regarding OB services are responsible for assessing and improving health outcomes and disparities among OB patients. So this is the data collection requirements But importantly, note that CMS is saying not only do you have to collect data around OB patients, you need to be collecting and stratifying that data around diverse subpopulations. Again, in their discussion of the maternal health crisis, CMS goes into great detail about the inequality, the impact of this crisis, from rural populations, minority populations, disabled individuals, that they are, through the data we have available to us, are certainly experiencing these complications more frequently, and thus CMS would require a hospital, a critical access hospital, as part of that QAPI program and collection of data to be tracking to those subpopulations. You're then also required to measure and analyze data on quality indicators, both on patient outcomes and review of processes of care, that you're looking at identified outcomes and developing action plans to address those outcomes and potential disparities, and also tracking performance across those measures to ensure that performance improvements are sustained, that you are conducting at least one measurable OB-focused performance improvement project annually within your organization. And then also there's a requirement that if there is a state or local maternal mortality review committee, and I think something like 49 states have an MMRC, that you are incorporating the data that is coming from your local MMRC into part of your QAPI program, so that you are in fact responding to regional and statewide issues as well. Next up is the change to the hospital discharge planning COP. So this is not a change to the critical access hospital discharging COP, because the COP already has requirements with regard to transfer procedures. So we're only updating the hospital COP here. The requirement we're adding to hospitals is that they maintain written policies and procedures for transferring patients to appropriate levels of care to meet specific patients' needs. And they also provide training to impacted staff on those policies and procedures. Note, this is not specific to OB transfers. It is a broad requirement with regard to transfer protocols, but it is, of course, around the discussion of when is it appropriate to transfer a patient that requires a higher level of care, and that would include, of course, our OB patients as they experience complications.
And Marty, I am assuming that this would also apply to REHs?
Not yet, Kathy, and that's an interesting part, is that in their discussion of the COPs, CMS notes that they are not proposing any changes to the rural emergency hospital conditions of participation, and instead have included a request for information as part of the proposed rule on how it should address these needs within rural emergency hospitals. So you're not off the hook, REHs.
I would have thought that at least on the transfer provisions, that
I would have expected that as well. Yeah, now REHs have a requirement to have transfer protocols, but it is not at the level of specificity that you're now seeing applied to the hospitals. So
I think it will be.
I think it will be too. And I think this, okay, let's talk emergency services COPs, because this I think is going to be the most impactful change, because the three requirements I've discussed previously only apply to facilities that in fact provide OB services outside of their emergency departments. They have formal OB programs. These changes to the emergency services COPs apply to all hospitals and all critical access hospitals. So even those that do not have OB services, that have closed their units, you are going to be subject to these emergency services conditions of participation. First of all, they are now proposing a requirement that you maintain protocols consistent with nationally recognized evidence-based guidelines for patients with emergency services, noting that this includes, but is not limited to, patients with OB emergencies, complications, and immediate post-delivery care. So again, we tend to read by this language, nationally recognized evidence-based guidelines, but again, CMS emphasizes here their expectation that you'll be actually citing the guidelines, the protocols that you're relying on, is establishing your protocols within your own organization. Secondly, you need to maintain within your facility adequate provisions readily available to treat emergencies. That would include equipment, supplies, drugs, and biologics commonly used in life savings emergencies. And again, they do not specify exactly what's required, that is to be determined based on what types of emergencies you see within your facility and your ability and capabilities to respond to emergencies within your organizations. But again, need to demonstrate why you chose what you chose. And then they do specify that each emergency services treatment area must have a call-in system for each patient. So they generally, again, you've seen that in the accreditation standards before. We're elevating it now to the level of a COB. And then where the rubber meets the road, training staff annually on those emergency protocols and provision requirements. Again, the governing body is charged the responsibility of identifying those who should go through the training and identifying that staff. That training must be informed by your organization's QAPI program findings. So as you evaluate emergency conditions, what are you learning about outcomes? What are you learning about challenges, and how are you incorporating that into your training? And then again, this requirement that you must be able to demonstrate staff knowledge on training topics. So important here, and I'm specifically going to call out our critical access hospitals that do not have current OB services. There is now an expectation that you have some capacity within the organization to respond to an OB emergency, and simply packing the mom up in a car and shipping her off to another hospital is not going to be adequate. You're going to have appropriate protocols for responding to these emergency situations when you've got a nurse practitioner that hasn't delivered a baby in 12 years, now in the ED, facing that particular challenge. And so we want to address those directly head on. I think this is a great opportunity for critical access hospitals to look for partnerships with hospitals in their regions to address these training and protocol needs. So Kathy, with that, I'm going to flip this back. Oh, no, wait, this is me.
No,
I forgot. Okay, so that's our changes to the COPS. Let's talk about the quality reporting programs. And in the proposed rule, we always address all three now: the outpatient quality reporting program, the ASC quality reporting, and the REH, Rural Emergency Hospital quality reporting programs. And what we see CMS doing in the proposed rule is incorporating into these quality reporting the three health equity related quality measures which were introduced for hospitals 2 years ago. So it is the organizational commitment to health equity measure, that is a attestation that the organization meets specified domains in its commitment to health equity. It is the screening for social drivers of health measure, the expectation that all adults, individuals who are 18 or more at the time of service, are screened across 5 health-related social needs, that being food insecurity, housing instability, transportation, utility differences, and interpersonal safety. That you're using a screening tool of your choice, but it's certain that that screening tool is adapting all 5. There is a very interesting discussion in the proposed rule of CMS's consideration that it would permit a hospital to roll this into one measure. So rather than having to report separately for the hospital inpatient quality program and the hospital outpatient quality program, that instead that data would be aggregated into a single reporting tool for the hospital. But they determined that there's enough differences between hospital inpatient populations and outpatient populations that it would be more appropriate to maintain a separate reporting tool for outpatients. They do note it is wholly appropriate that if your EHR indicates that a patient has been previously screened, that it is adequate to meet this measure to simply update that screening rather than taking them through the entire screening every single time. It's like every time we're asked what medications we're on, right, when we go to a doctor's appointment, that it is permissible to simply update a prior screening within an annual period. So that would click the numerator for that particular measure. Finally, the addition of the screen positive rate for social determinants of health measures. So those 5 areas, health-related social needs that you're screening for, you're reporting then on what's the positive rate, positive screen for that patient population. And of course, these are similarly going to have the numerator and denominator distinctions that were part of the inpatient rule. We're simply just now extending those requirements over to outpatient ASCs and rural emergency hospitals. Other changes made to the quality reporting programs. On the outpatient quality program, we've added some new measures regarding understanding key information following procedures. We've removed certain measures that we believe no longer provide useful data. We are requiring EHR technology to be certified to be able to report on all ECQMs that are available through the outpatient reporting program, similar to what we saw under the IQR program this spring. And then changes to what data will be reported to Care Compare. For our AFCs and our REHs, you also have some minor adjustments made to those quality programs as well in the proposed rule.
There are a number of, I guess I want to say, catch-all provisions that were included in this rule as well. I'm going to go through these very quickly. The first is the OPPS payment for remote services. This is your outpatient therapy, your outpatient mental health, diabetes self-management training, etc. These are services that you provide as a hospital on an outpatient basis, but are currently paid under you're thinking about them in terms of the requirements from a hospital perspective. Moving forward, based upon this proposed rule, you're going to have to apply those requirements for these services and the conditions for these services to the rules that are established under the physician fee schedule, as opposed to OPPS. They continue to be paid as they are, but you're going to have to follow different standards, perhaps.
And Kathy, just to preview to the next HCRR, we will address the Medicare physician fee schedule. CMS did one heck of a tap dance around the termination of the flexibilities for telehealth, as they are now online to end at the end of this year. No congressional action yet. So they sort of, here's what we intend to do if there's no renewal, and that would be not applicable just into the fee schedule, for also for these services furnished by hospitals.
Exactly. So you're going to have to look at, if you're providing these services on a hospital outpatient basis, but remotely, you're going to have to look at the physician rule and what comes out at the end, and how Congress responds in December 27th, I guess I would say. Other issue that was addressed, I thought it was an interesting one, was a special enrollment period for formerly incarcerated individuals. And what CMS has done in this particular rule is narrowed the definition of custody, because previously it was anyone who was still considered, they define incarcerated to include those who are on parole, probation, home detention, and like that. Now they are saying we're going to exclude that population, and we're going to follow the Social Security Administration determination of incarceration. So,
telling you, Kathy, we still need a law that says if you're convicted of Medicare fraud, you can never participate in the Medicare program. Damn it. Okay, sorry.
I would agree with that, but when you say participate, are you saying then as a patient as well? So,
right.
Who knows? Medicare fee-for-service prior authorizations, interesting provision. You know, there are just a handful of services that Medicare requires prior authorization for. These are some rhinoplasty services and such as that. They're going to move the standard time frame for issuing the authorizations from the current 10 days down to 7. So I assume they are comfortable that they can meet that requirement and have been meeting it. And then last but not least, and this is going to be contentious, I think, across the states, is the Medicaid and CHIP continuous eligibility. And this would be a requirement, interesting, included in the hospital outpatient proposed rule that would require states to provide a full year of continuous eligibility for children under the age of 19. So we've got a number of states who have essentially already adopted that, but then we've got others who have said they are not going to do continuous eligibility. Well, based upon this proposed rule, if finalized, it would require the states to adopt such a program. We'll see how this goes about in light of some other things we're going to discuss today. A couple of other proposed rules that were out there that we need to touch base on. End-stage renal disease, comments are due on this particular rule on August 26th. In terms of the payment update for this particular rule, we are looking at a 2.2% increase in the base rate over 2024, 3.9% increase for hospital-based ESRD facilities, 2.1 for freestanding facilities, so averages out to about 2.2. They are going to have the budget neutrality. The adjustment is based upon a budget neutrality adjustment of 0.99 and a 1.8% increase in the market basket. But the reason I wanted to make sure we included ESRD in this discussion today is what I think might become a issue for future on hospital inpatient, outpatient, and everything else. But go to the next slide and look at the ESRD specific wage index. Historically, for an ESRD PPS, they have used the hospital wage index. There's been a lot of discussion, particularly on the part of the Medicare Payment Advisory Commission, that the hospital wage index, the way it is calculated, is really not the best measure even for hospitals of an adjuster for the base rate. This is the first time we've seen this, but from CMS, but they are proposing to modify the wage index for ESRD facilities to use Bureau of Labor Statistics data, and then hospital cost report or freestanding ESRD facility cost reports. MedPAC has been pushing for BLS data for everything. I'm just wondering if this becomes a start of something we're going to see in future rulemaking next year. We talked in the inpatient rule about the revised core-based statistical areas. They will be adopting those for ESRD. For home health, again, comments are due on August 26th. And they are making adjustments, significant adjustments to the home health payment rate. They are very concerned that there is an imbalance between what the payments are for home health services and the actual costs of providing care. So although you have a lot of math on this page, essentially what we're looking at is about a 4.1% proposed decrease in the rates. So we are looking at a market basket of 3, less productivity, behavioral adjustment. We essentially wind up with about a 4.1% decrease in the rates, with a national standardized rate of about $2,000. So significant decrease in this particular program. That behavioral adjustment for budget neutrality with the transition to the new PDGM program, that is something that it would probably take legislation to get that adjusted and not have that in this final rule. Next slide. They will use the new CBSAs for wage index. They're going to recalibrate the home health resource groups using 2023 data. They're going to be adding SDOH assessments to OASIS related to food, living situation, and utilities. And a significant issue that I think home health agencies are going to have to spend some time not only on A, doing, but B, before that, commenting on, is that they would be updating the home health conditions of payment, not conditions of participation, but conditions of payment. But you would have to develop a patient acceptance service policy, and that would be developed to help patients select the best or the most appropriate agency. But you're going to have a policy that addresses who do I take and who do I turn away? Issues of capacity and issues of your staffing, the case mix of the individual patients, your current population of patients, your caseload, all of this, and how do I then say, do I take this patient or not? What are my evaluators? And that this would be a program, that a policy that you would have to develop, use as an ongoing condition of payment.
Hey, Kathy, I should have mentioned this when we were talking about the OB COPS, and a condition of payment and a condition of participation and a condition of participate. They're all the same thing, right? Yeah. But they name them differently. But in these proposals, there's no effective dates. And I expect what we'll see is these are finalized. We'll see the effective dates then. But generally, what we've experienced previously with COP changes is sort of tiered effective dates. So this is effective then, this is effective that way. I think that's a really important item to comment on, is really evaluating, how much of a lift would it be to do all this training in our emergency departments, or what's a lift to develop this type of policy when there's really no industry standard at this point in time. It's important to comment of make sure we get adequate time, and comment that we need interpretive guidelines in a timely manner as well. Not that I'm Johnny one note on that issue or anything, but so be it.
The Office of the National Coordinator, a couple of rules that we want to address, one proposed, one final. So we're going to start with the final rule that came out on June 24th. And this relates to information blocking disincentives. And it essentially takes the current requirements of promoting interoperability. We've got it on promoting interoperability. Now we're going to look and tie into interoperability, tie in information blocking. It becomes a part, one and the same. And the issue of information blocking, that would be when you have a practice that interferes with the exchange or use of electronic health information. So essentially the finalized disincentives are the same things that we currently see for the interoperability, the meaningful user program, effective 30 days after the final rule comes out, a 75% reduction to the market basket for hospitals. Critical access hospitals would see payments reduced to 100% of reasonable cost rather than 101. And for physicians and other Part B providers in the MIPS promoting interoperability performance category, you would have a 0 score. They are looking that effective in January of 2025 for accountable care organizations, they would be ineligible for MSSP for at least a year, and they would be moving forward with reporting all information blockers on the ONC's website. So,
what's the difference between a disincentive and a penalty?
Exactly. Yeah. And then we also have on July 10th, another ONC rule that this one was proposed. And we talked, I guess it was in January, with HTI 1, which really talked about using technology and standards for authorizations and things like that. But what we are looking at here is basically a stated goal of improving public health response and advance the delivery of value-based care. What they are essentially proposing to do is to develop standards that standards-based applications to improve interoperability between data exchange providers. And they are proposing technology and standards for exchanging clinical images, X-rays, for using multi-factor authentication, and for real-time prescription benefit certification tool. If I want to have my prescriptions authorized at the time of ordering, how do I have it? What kind of tool do I have to address this? One thing that's interesting in this is going to be interactive between providers and payers and payers and payers, but does anybody see advanced explanation of benefits here? No.
Interesting.
Last rule that I wanted to touch on is another.
Hey, Kathy, one thing,
Yes.
I looked, I can't find this rule on the public inspection website, so I can't give a date by which we can anticipate comments are due, but I would put it in this mid-September range.
Yeah, I would agree.
So
this one came out July 10th. That was essentially basically ties in with the OPPS rule and the physician rule, so I think we're looking at the same. And then finally, we have a rule that's, if you read it directly, you're thinking this doesn't have an impact on me because it applies to credit reporting agencies, but it has a huge impact on providers. So this is from the, relates to the credit reporting of medical debt. And this was published in the June 18th Federal Register, comments due August 12th. Those of you who are on revenue cycle, I really think you need to start commenting on this because the issue here is that it would stop the inclusion of medical debt in credit evaluations. It doesn't mean that as a provider, you can't report a debt to a credit agency. It just means that when they do their evaluations of a credit score, they can't include medical debt. They say basically in the rule that a consumer reporting agency generally would be prohibited from furnishing to a creditor a consumer report containing medical debt information in connection with credit eligibility determination. And I think an interesting statement in the rule, but tells you where they're coming from. Consumers would no longer be unfairly penalized in the credit market for having medical debt. But what does this do from a provider perspective on your ability to collect patient responsibility? What is their motivation to pay? It's going to be reported to an agency, but they can't use it. From a provider perspective, you're probably going to have to very definitely strengthen your upfront collection activities, put processes in place to make sure you're collecting what you can upfront. Concerned that this will have impact on your overall revenue moving forward from the patient responsibility. And one of the things that was kind of insightful in this rule is that they said, we know this could impact providers, but they can always resort to litigation to collect the debts. That gets very expensive, very costly, and staff requirements and everything else. So I do think it's something that is definitely worthy hospitals and other providers commenting on. Marty?
Let's shift gears and move over from our friends in Baltimore at CMS to our friends on First Street in Washington, D.C., the Supreme Court. And we're going to talk about a couple of decisions that have come down and do a little bit of crystal ball work in terms of what we can anticipate happening. The first of those decisions is United States versus Idaho, which is the EMTALA preemption of state abortion laws. So the decision came down in late June, and we're still seeing what the impact of this is going to be going forward. So go back to the summer of 2022, we have the Dobbs decision that overturns Roe v. Wade. Shortly after that decision, CMS publishes a memorandum which highlights the conflict between state abortion restrictions and EMTALA obligations. And you see on the screen there sort of the golden paragraph where CMS took the position that EMTALA requires a hospital to provide stabilizing treatment when an individual has an emergency medical condition, and that if appropriate, if an abortion is the appropriate stabilizing treatment, then EMTALA trumps any restriction in state law on the abortion. When that memorandum came out, there were a number of states that sued and claimed that EMTALA would not preempt state abortion laws. And one of the first to get to court was the state of Idaho. And the federal district court in Idaho enjoined the enforcement of the state's abortion ban, which only allows abortions in the case of the life of the mother or rape or incest. But they enjoined that restriction to the extent it would prevent the delivery of stabilizing treatment for an individual with a pregnancy-related emergency medical condition. That decision by the federal district court, that injunction, was appealed to the Ninth Circuit, and the Ninth Circuit upheld the injunction. So then in January, this case makes its way to the Supreme Court, and to everyone's surprise, the Supreme Court lifted the injunction and agreed to consider the case, in part because part of the reason that it was a surprise was that this case really had not been fully litigated yet. It had only been litigated to the point of the court issuing the injunction. They had not yet reached the merits of the case and issued a decision. But the Supreme Court heard oral argument on the case, and then in June, as we were starting to get sort of the landslide of opinions at the end of the term, we get an order, which actually was reported first in the media, sort of like Dobbs had been leaked. This decision ended up being leaked, but it really wasn't a decision. It was a very simple order that reinstated the injunction issued by the Idaho federal court and remanded the case for further proceedings. And there's no official opinion, no formal opinion that accompanies that decision. Instead, you have sort of this collection of concurring and dissenting opinions that reflect very differing views on the part of the 9 justices. But what we know is that the court's decided it's not going to get in the middle of this abortion issue, most likely during an election year. And so the Biden administration, shortly after this decision came out, issued another memorandum similar to the July 11/22 memorandum, where they said that they fully intend to continue EMTALA investigations of hospitals that refuse to provide abortion as stabilizing treatment. What's interesting about EMTALA is we never really know what's going on in the enforcement world. You know, EMTALA is another, like conditions of participation, EMTALA is a statute where the remedy is you lose your Medicare participation agreement. And so heavy-handed, CMS can be pretty forceful in its investigation of EMTALA by a potential EMTALA in violations. In addition to saying we're going to continue these investigations because we think EMTALA still preempts state abortion laws, they've also said that we're going to continue to encourage individuals to report what they believe to be EMTALA violations. And now, for example, they've added a Spanish language complaint form on their website. So this is going to continue.
You can complain through a portal now.
Yeah, you can't, exactly. You don't have to, they're definitely opened up the opportunities to complain about any EMTALA violation, not specifically a refusal to provide abortion, but any refusal of appropriate stabilizing treatment. But it is clear that the administration at this point intends to be very aggressive on this matter, leaving hospitals in states with restrictive abortion laws to figure out how they're going to walk this line. It is very difficult, and really it is a matter you're going to have to handle within your organization to make the decision before the case shows up in your ER. That's the one thing we would offer you, is work through these issues now and don't wait until you have the pregnant mother with serious complications to determine how you're going to respond. And now, Kathy, we did it. It's 10:46 and we made it to Chevron. Let's talk Chevron.
So now we need to fill up the car here at Chevron.
Not exactly. That's not exactly what Chevron is. But that big noise you heard was our current understanding of the regulatory environment shifting as the Supreme Court handed down its decision in Loper Enterprises overturning 40 years of Chevron deference. And what does all that mean? Well, let's start at the beginning. What is Chevron deference? You'll hear this is the Chevron doctrine. That's not right. It's the Chevron deference policy. And this goes back to 1984 during the Reagan administration when the EPA had promulgated certain regulations regarding the Clean Air Act. And what the EPA argued for before the Supreme Court was that federal courts should defer to an agency interpretation of a statute rather than imposing its best reading of a statute. So this would be deference to an agency determination. And in fact, since '84, the Chevron deference has been applied in over 18,000 cases challenging agency actions. So here's how it works. Best explanation I can try and provide to this. The first question a court gets to is the statutory provision on which the agency promulgated the regulation. Is that statute ambiguous? And the word ambiguous actually has a meaning. It is the provision subject to 2 or more reasonable interpretations. That makes a statute ambiguous. If the court determines the statute is not ambiguous, the court then must evaluate the regulation at issue for compliance with the unambiguous statutory language. That is referred to as Chevron Step 1. So unambiguous language, the court's role is to compare the regulation and determine whether it is within the confines of that ambiguous statutory language. If, however, the statutory language is ambiguous, and heaven knows the Social Security Act is a study in ambiguity in places.
We had it today. We just discussed the issue of the definition of the word custody.
Exactly.
Because CMS has been using one definition of custody and the Social Security Administration has been using another.
So there you have it. They're right, a perfect example. But if the court determines that the statutory provision on which the agency based its regulation is ambiguous, Chevron said, wait, your role now is not to determine what the statute means. Your role is to determine whether the regulation promulgated by the agency is a permissible construction, not necessarily the best construction, but it is a reasonable construction of statute, because you're going to assume that in leaving ambiguity in the statute, Congress was delegating authority to the agency to interpret ambiguous statutory provisions. So then if the court determines it is a permissible construction, the court is then upholding the regulation and deferring to the agency. And some legal analysis say something like 94% of cases that reach step 2 in Chevron deference, in fact, did defer to agency action. But there are those cases when the court says, no, that is not a permissible construction of the statute. It is arbitrary and capricious. Sometimes you'll hear that language. Then generally the courts will remand to the agency to revise the regulation per the requirements of the opinion issued by the court. Now, Chevron ain't pretty in its application because there's a number of very practical challenges in applying Chevron. And remember, Chevron deference only applies to an agency's interpretation of a statute. It does not apply to an agency's interpretation of its own regulations, for example, and that is its own separate regulatory challenge. But what other challenge we've had with Chevron is, what do we do when Congress directs an agency to promulgate implementing regulations, effectively gap filling? And again, Social Security Act is loaded with direction to the Secretary, HHS, i.e. CMS, to promulgate regulations implementing the statute. So how exactly do you apply Chevron deference in those cases? And then also there's this issue of when the statute is completely silent on a matter that's critical to regulatory scheme, such as the definition of key terms, where there's no indication of what Congress meant, and the term could be interpreted in a number of different ways, such as we said, just said, Kathy, custody. So those have been our challenges with Chevron. You know, Chevron started in the Reagan administration and then quickly became the bane of the conservatives, and that they were eager to overturn Chevron because they thought it built up too much administrative power. And so finally in Loper Bright Enterprises, the Supreme Court took the action that many predicted they were going to do and ended Chevron deference, holding that under the Administrative Procedures Act, the APA, courts, not agencies, are the final authority for interpreting statutes. And again, on the screen, you have sort of the money paragraph out of Justice, oh my goodness, who wrote the majority opinion, Kathy? I'm totally blanking. Well, shame on me, but it is out of the majority opinion. And the key here is that last line: the courts need not and may not defer to agency interpretation simply because a statute is ambiguous. So this idea that ambiguity equals a delegation of authority to an agency, they said that is not permissible under the Administrative Procedures Act.
And finally, was it Clarence Thomas?
I'm not certain, and I'm not going to guess. That one of them, I can't remember who wrote it. It's embarrassing. But the key language is a statute still has a best meaning, necessarily discernible by a court, deploying its full interpretive toolkit. So armed and ready, the federal courts have now been directed that they are responsible for resolving ambiguities in the statutes, and no longer any deference to administrative interpretation. Now, the decision does reference that we certainly should give weight to what an agency does, particularly if an agency is dealing in a highly specialized area, which requires, numerous different considerations, such as CMS, interpreting the Social Security Act. But that still is not the end-all be-all, and that the court is responsible for determining the best meaning of a statute. Now, we weren't done. Loper Bright Enterprises wasn't the only decision that impacted Chevron deference. On July 2nd, I believe, the Supreme Court issued its decision in Corner Post. And Corner Post was a challenge to the 6-year statute of limitations in the Administrative Procedures Act. And there had been a split in the circuits Some had said that 6 years runs from the date that the agency promulgates the regulations, where others had said it runs from 6 years from the date that the plaintiff first suffered injury as a result of the regulation. And the Supreme Court adopted the latter formulation, meaning that, and in the case of Corner Post, the entity that brought that lawsuit didn't even exist at the time that the regulation was promulgated. And so even if you don't even come into existence after the fact, years and years later, you have the opportunity to challenge the agency and their decision. And when you add to that the end of Chevron deference, welcome to the wild, wild west in terms of what's going to happen going forward. So now what? And this, again, as I said, is completely crystal ball activity and a dangerous sport, as Kathy and I will now.
And before you go on, we should be both embarrassed because I believe it was Roberts who authored the opinion.
Oh, Chief Justice Roberts, great. Okay, now we know.
So now we're done. No, I'm only kidding.
No, exactly. In terms of litigation, and there has been a lot that's already gone on since the end of June. The Texas Medical Association, which we know and love as the group that challenges No Surprises Act regulation, they have already said that they are looking seriously at challenging the entirety of the No Surprises Act regulations under the new non-Chevron deference. A couple of academic medical centers filed lawsuit last week, I believe, challenging how CMS did GME payment recalculations. This actually was a recalculation that followed successful litigation, and now the AMCs are challenging the way in which CMS calculated the recalculation. So that lawsuit has been filed, and again, citing Chevron deference. And then the American Home Care Association has its challenge to the nursing home minimum standard requirements. At this point, they have not raised the Chevron issue, but have indicated in public reports that they're going to do so. One thing to note about the Chevron decision, it very clearly states that it does not reverse any decision made previously in reliance on Chevron. That was very clear from the oral argument. There was at least one justice who wasn't going to go that far. And so as sort of a split the baby approach, the majority opinion says that we are not reversing any prior decision based on its reliance on Chevron. That will simply have to work its way through the courts. So what we thought was previously settled law may not be settled law. Then Kathy and I said, well, what else is potentially going to be challenged under where are these lawsuits going to go? And the first one we came up with immediately was budget neutrality and HOPD status. Because if you remember, when Kathy talked about the OPPS rule, there was nothing about budget neutrality, and about site neutrality. That's to be site neutrality, excuse me, not budget neutrality, site neutrality.
Well, no, it's budget neutrality in terms of the rate.
Right, but it's the payment rates, and this was the topic. I mean, this is what we expected CMS to come out guns a-blazing in OPPS with more proposals to eliminate site neutrality. There's nothing in there. So it's kind of a question, are they starting to appreciate they have some issues? Certainly we expect to see something around Medicare Advantage, all the regulations that have been flying around that. State challenges to Medicaid rules, such as Kathy just referenced, the continuous eligibility issue. Hospital qualification for special status like critical access hospital or cell community hospital, sort of the rules that CMS has created around those that are not necessarily squared up with the statutory language. The change in the rules on at-home care reimbursement rate, that the requirement that you have to spend 80% of the reimbursement you receive on wages for the actual at-home care workers. Where did that come from, the statute, they may be asking. This issue around 340B contract pharmacies, the pharmaceutical companies saying we want to limit the number of contract pharmacies, and CMS taking the position like, no, you can't. Where are we going to see that going? And then certainly a whole bunch of issues around the Affordable Care Act and its regulation of health plans. Such as the required disclosures on fixed indemnity insurance plans. Is that going to be subject to challenge? And really, that's a short list.
Well, a couple of other big ones that I wanted to mention, Marty, that impacting hospitals. The biggest one that has been, I think, in the news for years is the Alina issue. And that goes back to the calculation of Medicare Part C days for the SSI fraction of disproportionate share. Essentially, that has worked its way to the Supreme Court over the years, but then CMS actually came out with a regulation following that where they did a retroactive rulemaking on the issue of the calculation. And that has hurt a lot of hospitals, so that becomes an issue. The other one that is predominantly an issue, I think, in those states that have, well, I guess it would be those who have what I would call an uncompensated care pool under an 1115 waiver. Florida recently had a fairly, well, a very successful litigation that has now expanded to other states. We actually did go to the Supreme Court on this particular one, where we were able to identify those individuals who were covered under an uncompensated care pool, but were not Medicaid eligible, but they were funded through the Medicaid uncompensated care pool, that they actually did count for the calculation of disproportionate share. That becomes an issue in terms, because CMS has also shut that down in terms of issuing a rule earlier, well, late last year, that basically turned off the ability to count those 1115 waiver days. So what happens there for other providers? So those become some issues that I think we're going to be seeing very quickly.
So there's Fitch Rating Service published a report last week where they said that Chevron, the end of Chevron, Loper Enterprises, will have profound implications on the healthcare industry. What does that mean? Will we see more specific statutory language, especially regarding delegation of authority to the agencies? Will we even see legislation out of Congress is usually my question, Kathy, but now the onus is on Congress to say what it means better. Are we going to see longer Federal Register notices? Is that even possible? Exactly, but the agency is having to do a better job of addressing comments and providing the explanation for their decisions. Are we going to see agency timidity? And not just in the sense of what are they going to do with site neutral payments, but what about the regulation of artificial intelligence or payment for virtual services? Are they going to back off? Because there's no clear authority in the Social Security Act for them to do so, but obviously the industry needs that regulation, is asking for that regulation. What are we going to see there? Certainly some sibling rivalry or tribalism, because now hospital A wants something, but hospital B wants something else. So no longer are you going to really see this litigation or even advocacy coming out of the associations. It may end up being at the much more hospital level as they argue their positions.
You're going to have to be commenting for you.
Yeah. For you, exactly. And then reduced, again, what Fitch was going to in its report was reduced access to capital due to market uncertainty, is that you've just sort of turned this an industry that is heavily regulated, but relies on its regulation for predictability, losing that predictability. And you certainly know that what do investors hate? They hate uncertainty. And we've just introduced that into healthcare at a new level. And then there's just chaos. And remember, Chevron was during the Reagan administration, and they ended up hating it. And are we going to see the same thing now with Loper Bright? Is that we're come to hate the solution that we saw. Very quickly, just to wrap us up, I know we're going to go a few minutes over here, but there have been some recent federal court decisions that have been enjoining final rules we previously talked about. That starts with the Section 1557 rule, if you recall. This is a provision in the Affordable Care Act that prohibits discrimination in healthcare programs. A number of key provisions in that final rule when it was published, including the definition of what constitutes sex discrimination. We've had two decisions handed down thus far. Tennessee versus Becerra, I always say it wrong, excuse me, which is now a nationwide injunction on the provision that extends discrimination on the basis of sex to include discrimination on the basis of gender identity. So it's a very specific line item injunction on the rule itself. However, a separate decision, Texas versus Becerra, actually enjoined the entirety of the rule in the states of Texas and Montana. So welcome to a patchwork quilt of court decisions, because the court in Texas said, well, we're only going to apply to Texas and Montana, whereas in Tennessee, they said we're going to issue a nationwide injunction. The Federal Trade Commission non-compete final rule, which is intended to go into effect on September 4th, which is really soon. This prohibits the use of non-competes going forward. We have a couple of decisions here, beginning with the one down in Texas, where the court said FTC does not have the authority to promulgate regulations that define what is and is not an unfair trade practice. Interestingly, in issuing that decision, the court declined to issue a nationwide injunction and only issued the injunction with respect to the actual claimants in that case. But they have said that they will issue a final opinion. The court, said she will issue a final opinion on August 30, which is, 5 days before the effective date, which may or may not enjoin the decision. We also have a case up in Pennsylvania that's running on the FTC non-compete rule. The court says it will issue an opinion by July 24th, at least a little sooner. But regardless of what's happening in terms of this rule, note that FTC is becoming more aggressive in its investigation of companies that are using non-competes as an unfair trade practice. Announced this week was confirmation by DaVita and Fresenius that they are being investigated on this point. And we still have the ongoing U.S. Anesthesia Partners case where they've reached a settlement in Colorado, but it still has other implications nationwide. Finally, last but not least, the MA broker compensation rules. If you recall, CMS promulgated the MA final rule in May of this year, establishing fixed per beneficiary broker compensation and imposed restrictions on data sharing. This was intended to sort of eliminate adverse incentives in broker recruitment of potential MA beneficiaries. In the decision in Americans for Beneficiary Choice, again out of Texas, the court said the compensation rules are arbitrary and capricious, that they enjoined the use of those rules for the 2025 plan recruitment period because they were promulgated without complying with necessary procedural requirements. The good news is the court did uphold the restrictions on data sharing. So the fact that one MA plan has your contact information does not mean that all MA plans will have your contact information. But it'll be interesting to see how this one moves forward. There's a hint of Loper Enterprises in this decision, but it's not a full-throated, we know we're going to follow Chevron. So again, the old Chinese proverb, the old Chinese, may you live in interesting times. I think we are there, Kathy.
Absolutely.
And speaking of interesting times, we also on July 10th not only got the OPPS rule, we received the Medicare Physician Fee Schedule rule. I think it weighed in at about 2,200 pages. So on July 31st, the PYA team will tackle that rule and highlight key provisions. And then we will follow in August with the 2025 final rules, which IPPS, SNF, and all of our good friends. So thanks for joining us. Again, apologize for going a few minutes over, but there's just so much to talk about these days.
Thanks for staying with us.
Thanks to our presenters, Martie and Kathy. Later today, you will receive an email with their contact information and a recording of the webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete a short survey and post any questions you may have. On behalf of PYA, thank you for joining us and have a great rest of your day.